So how's everybody doing today? Hope you had a great weekend. Well, I was at the ACP meeting last week in Nashville. Great meeting, good town, a lot of fun seeing everybody. Some good information coming down on the world of phlebology. If you didn't make it this year, make sure to attend next year. It's a very worthwhile meeting. Well, because of that, I'm kind of in the vein mindset. Really didn't have a lot of cases together. But yesterday, I was scanning a patient and came across a fair picture of a perforating vein. So I thought I might kind of share a few thoughts with you on that. Yep, you know what day it is. Technical Tip Tuesday. Just a quick review of the venous system of the lower extremity. Of course, we know it's made up of 3 systems located in 2 separate compartments. The deep venous system located in the deep muscular compartment, the superficial venous system located in the superficial compartment, and of course there's that special compartment, the saphenous compartment, and through those course the great and the small saphenous veins. Now, the systems are connected by the perforating venous system. So, the perforating venous systems perforate that fascial layer to connect the superficial and deep venous systems, and thus also connect the superficial and deep compartments. Perforators are very important because they carry blood from the superficial system down to the deep system, which carries the blood or the majority of blood out of the leg. Make sure you use proper terminology. Gone are the Cockett and the Boyd and Sherman perforators. Terminology of perforators is based on topography. So here's my patient. She was C2, has some varicose veins. Here's the left saphenofemoral junction with a valsalva. Not completely clean. Maybe we could think about including that little extra blip, but certainly to me, this is pretty competent here with a good effort valsalva. Possibly a little dilated. She was a little chubby, not the best picture in the world, but about 8.5 millimeters. She didn't really have any reflux up in the upper thigh. However, as I got into the distal thigh and at the knee, there was clear reflux with release of distal compression. Of course, we do all these patients in a standing position. Her great saphenous at the knee measured 5.3 millimeters. So possibly a little large than we typically see, but that kind of fits with the reflux. So I'm following the great saphenous vein down below the knee, and I run into this prominent perforator. I note, because of the topography, this is a paratibial perforator. Now, forgive me for not having the machine tweaked optimally, but I'm also inclined to show you some real-world clinical type of examples. So forgive me if I'm overgained a little bit. But let's interpret this. I have the great saphenous vein to the left. Notice I'm steered off to the left, and so I see flow towards the transducer. This is kind of retrograde flow. And then normally flow down into the deep system through that perforator. So I'm going to show you a little video clip here. We'll start out with a distal augmentation, and you can see flow through the great saphenous going cephalad, and then upon release, you see reflux through the proximal portion of the vein, but then re-entering the deep system via that perforator. So really what I wanted to talk about is this concept of a re-entry perforator. Even if there's reflux in a reentry perforator, many times that's important to empty the superficial system or decompress the superficial system in the case of reflux or other dysfunction to allow blood to get out of the limb. Remember, it does that via the deep system. So this concept of a reentry perforator is very important and in fact oftentimes normal following intervention. Keep that in mind. So in our patients, it's very important to differentiate refluxing perforating veins from pathologic perforating veins. Let's look at an example. Actually, I borrowed this from a previous presentation here on Virtual Vascular Lab. Here's a mid-calf perforator, 8.2 millimeters. Wow, that's pretty large. A lot of reflux. So what do you think? Is this pathologic? So you got to remember, a pathologic incompetent perforator vein is defined as one that's greater than 3.5 millimeters, one that exhibits outward flow greater than a half a second, 500 milliseconds, and one that's located beneath an active or a healed ulceration. So if there's no ulceration, it's not really considered pathologic. Remember, refluxing perforating veins may in fact be a necessary vessel. Hope you enjoyed Technical Tip Tuesday on my perforating vein and a few thoughts surrounding that. You know what to do. Like, subscribe, keep those comments coming. We're always looking for suggestions as for future cases that you'd like to see, or if you have a good one, we're always looking for material. Please contact us. It's getting near the end of the year. If you need any CME, we got you covered. Go to virtualveincenter.com. My name's Bill Schroeder. You guys go out and have a nice week.